Before I start the show, I want to wish you all the best during this hard time. We are all affected in different ways by COVID-19. For fellow genetic counseling students, especially those also in the class of 2020, it's been a lot of changes with campuses closing, so I hope you are all safe. Picture Genetics is a new and unique DNA testing service. These tests are designed for every stage of life, from family planning and newborn health to personal wellness and disease risk. Unlike other companies, this is actually a clinical grade test where physicians and genetic counselors are involved. The test sequences entire genes that are medically actionable. It's easy to order and understand with really good looking reports. With some genetic testing, you only get a report, but Fulgent goes the extra mile and you're supported with live chats, emails, and even genetic counseling. To order your Picture Genetics, use code DNA Today for 25% off and free shipping.
How is it that we find ourselves surrounded by such complexity, such elegance?
The genes of you and me, the genes of you and me, we're all made of DNA. We're all made of the same chemical DNA. We're all made of DNA.
Hello, you're listening to DNA Today, a genetics podcast and radio show. I'm your host, Kira Deneen. On this show, I explore genetics' impact on our health through conversations with leaders in genetics. These are genetic counselors, researchers, doctors, patient advocates, and more. My guest today is Zaki Sabet. He's been with Precipio since co-founding the company in 2011 and currently serves as the COO. He holds over 15 years of experience in laboratory management, spanning all fields of reference laboratory operations, primarily focusing on cancer diagnostics, which is the focus of our conversation in this episode. Previously, Zaki has served as a consultant with the College of American Pathologists for many years, as well as several diagnostic companies, and setting up their specialized cancer testing operations. Zaki holds a Bachelor of Science degree in biomedical engineering from the New Jersey Institute of Technology. Thank you so much, Zaki, for joining the show. I'm really excited to jump into our conversation about hematologic cancers. Before we talk about diagnosis and that whole process, can you give our audience a bit of a background on hematologic cancers and what they are? What are the main types of them for those that may have no idea, no background in this?
Sure. Thank you, Kira, for having us. Just a quick background. Hematologic cancers are those that stem from the blood and or bone marrow physiological systems. A couple of main examples that some people may be familiar with are the lymphomas and leukemias are the two main categories of these types of cancers. Most people have heard of several types of lymphomas or leukemias, and multiple myeloma is certainly another one that falls into this category.
So within the lymphomas, leukemias, there's also a lot of different subtypes within that. So those are kind of the two. There's the main umbrella of hematologic cancers and then the two umbrellas under that. And then it kind of falls into there like a web.
Exactly. Yeah. And that's actually one of the reasons why it poses such a challenge in properly diagnosing these types of cancers, because just a rough estimate, underneath the lymphoma category, there's about 100 subtypes or subcategories underneath the main umbrella. And similarly with leukemias, there's also about 100 or so subcategories underneath that. So an individual, a pathologist who specializes in this really has a very large playing field that they have to be able to determine diseases from one another.
And this is so many different subtypes. I mean, you're talking about like 100 for each of the two, like lymphoma, leukemia. When we look at other cancers, we don't see that many. If I'm thinking of like breast cancer, we don't have hundreds of different types. So this is kind of unique in terms of cancers to have that many different subtypes. How common is hematologic cancers as a whole when looking at cancer? So obviously there's lots of different cancers. When you're looking at all of cancer, what % of them are these hematologic cancers?
Yeah, so you bring up a very good point. So the hematologic cancers do have a lot more subcategories than other types of cancers that occur. As a whole, they don't represent a very large portion of all cancers that occur that we know of today. So they're actually less than 10% of all types of cancers, which in itself create a challenge because there are not that many specialists around who specialize in these types of cancers because they're not that common. But they are one of the most difficult to diagnose. Number one, because there are so many subtypes of them. And two, because there are several types of technologies that we need to utilize in our diagnostic process to be able to properly diagnose these cancers. And For those two reasons alone, that's why we have seen in literature that there exists a higher rate of misdiagnosis in hematologic cancers as opposed to other types of cancers. When you look at breast cancer and lung cancer, colorectal cancer, there are not that many subtypes or subcategories of these types of cancers. And at the same time, there are not that many technologies at play to properly diagnose these. So a pathologist, a trained pathologist in these other areas has I don't want to say an easier time to properly identify the cancer that is occurring in the sample that they are analyzing, but certainly easier when compared to hematologic or blood type cancers, because they have to put together a lot more pieces when diagnosing hematologic cancers as opposed to breast or other solid tumor types of cancers. So that's one, but the other part of it as well is from the clinical standpoint. So a clinician or the oncologist that is examining the patient, because these hematologic cancers are, described as fluid cancers, if you will, because they exist in the blood system, they're not an actual mass that exists somewhere in an individual's body, as opposed to solid tumors where it's easier to identify clinically. And then the diagnostic process it stems from the identification, right? So an oncologist identifies, a breast tumor or a mass in the breast tissue. They take a biopsy or a sample of that, and their suspicion towards breast cancer is highly likely because that mass exists in that organ or that tissue, right? So they start the diagnostic process at a much higher confidence level than they do in the hematologic space. So when an individual is suspected to have a hematologic type of cancer in the blood or the bone marrow, the clinician is, basing that off of a complete blood count, a CBC that they typically perform, and other very vague signs and symptoms that these patients typically present with, right? Like anemia, fever, a little bit of pain here and there, right? So there are all symptoms that are not as definitive as they are when it comes to other types of cancers. So the clinician's likelihood to suspect the right type of cancer is also not as high from an accuracy perspective as these other types of cancers, which then also leads to the challenge of properly diagnosing these.
So it's less streamlined in terms of like when we're comparing it to breast cancer, you're saying we see a mass, we take a biopsy of taking a few cells of that and testing it. That's more of a straightforward approach. You're identifying the mass, you'll take a sample from that and test, okay, let's look at this tumor or, what we think could be a tumor. Whereas for this, you have so much more information you're collecting to be able to make a decision. It's not, do I have a test or not? It becomes what type of test and which is the best in terms of getting that answer. It doesn't sound like it's a one-step approach.
Absolutely. Yeah, it's actually a multi-step approach. Exactly as you pointed out, it's not as streamlined as it is when it comes to solid tumors because, and as you put it rightfully so, there is no identifiable mass that we're going based off of, right? And even when we do, or even if we do other types of scans on the body, whether it be, CT scan or MRI or other technologies that are utilized in the solid tumor space, nothing shows up when it comes to hematologic cancers, right? Because these are fluid type cancers. These are cancers that are occurring on the blood cell level, and these are flowing throughout the body, stemming from the bone marrow system. Sometimes it's happening in the lymph nodes. So the very few types of hematologic type cancers that are slightly easier or closer to compare to solid tumors are those that occur in the lymph nodes, right? So patients will present with enlarged lymph nodes, and there's a likelihood of them having a type of lymphoma, right? But all the other types are occurring in the fluid space. So there isn't one particular mass or anything in particular that can be pointed at to say, there's something going on there with this patient. Let me take a sample of it and send it to the lab for testing.
And you mentioned earlier of deciding these tests when the physician has a patient that they suspect has some kind of hematologic cancer. I mean, that would be almost step zero in all of this, to have that suspicion, and then deciding to order clinical testing and deciding, okay, what test is actually the best for this? How does this play a role? I imagine oftentimes physicians say, well, I think maybe it could be, a type of leukemia, let's say ALL, and then they have that testing. But if that comes back negative, I mean, how long is this process taking? And are a lot of patients receiving a misdiagnosis at some point in the process?
Yes, absolutely. And that's a very good point. And unfortunately, in our industry, in diagnostic laboratory medicine, the process is primarily driven by the clinician's input, right, or the clinician's suspicion. So when a clinician draws a sample from their patient, whether it be blood or bone marrow, they need to send it to the lab and direct the lab in the, regarding what they are suspecting. So just like you pointed out, if the clinician draws a sample and sends it to the lab, they tell the lab, I suspect my patient has an acute leukemia, an ALL or an AML, right? And that gives the lab the information they need to drive testing. Now, oftentimes, and we've actually seen that in our own laboratory and the data that we've collected, that the clinician's suspicion is usually wrong. And we have found from our own data that the incoming clinical indication or the information provided to us by the clinician is actually incorrect more than 50% of the time.
More than 50%. So in half of cases, or over half of cases, what the doctor thinks the indication is, if I have this patient, I think, we're going with this ALL. I think they have ALL. In more than half cases, it's wrong. How does that then affect the patient in terms of, I'm sure the testing then takes a lot longer, and that diagnostic odyssey that usually I talk about with, rare diseases applies here. I would think of it taking much longer than, say, as we were talking about, like a breast cancer patient, of the testing was positive or negative.
Right. Yeah. And the diagnostic process for hematologic type cancer is already a lengthy one, right? So we're talking about several weeks of testing. And when the laboratory or the testing is driven in the wrong direction, you obviously risk a higher likelihood of missing the malignancy, right? Because if you are a laboratory and you're directed to go down one pathway, if you don't find what you're looking for, as the saying goes, if you don't know what you're looking for, you're not going to find it, right? So, and oftentimes in these situations, most laboratories have testing processes that are so specific, that are geared towards what the clinician directs them to do, that they don't have visibility, or they haven't created some kind of visibility to capture things in the periphery. And that in itself, so we at Precipio, we've decided actually to do something about that, because from our inception, our company was started and built upon the concept of doing something about the problem of misdiagnosis in cancer. And we made a decision to start with hematologic type cancers, because we saw that has the higher rates of misdiagnosis, and a bigger part of the problem exists in the hematologic space as opposed to other types of cancers. And when we found, in our experience, in our own data, that clinicians oftentimes are suspecting the wrong type of disease, we actually instituted a slightly different process in our laboratory than other laboratories have. And that process actually consists of a triaging phase. Right. And you and I go to the doctor or go to a hospital, right? The first thing that typically happens is we get triaged, right? Either by a nurse or a PA. Somebody takes a preliminary look and evaluates the complaints that we come in with, right? And they do sort of their own preliminary assessment before they initiate anything else beyond that, right? Nowhere else in our healthcare system do the patient come in, complain about one thing, and then all the tests are triggered from there. But that's what happens in the oncology laboratory space, right? The sample comes in, and we'll use the sample as the patient in this situation comes into the laboratory, and the chief complaint is, I suspect my patient has lymphoma. And with that piece of information alone, most laboratories will trigger automatically testing for lymphoma. But what we have done at Precipio is that when that case comes in and the clinician gives us that piece of information, we then take that in the context of all the other clinical information they've provided us with, which includes the CVC, the complete blood count, and their complete clinical history and clinical information that they've obtained in evaluating their patient. And us as diagnosticians, we do a full evaluation of that information, and we do one of two things. We want to make sure that that information aligns with the clinician's suspicion, and if it doesn't, we need to come up with another approach, right, or another disease suspicion that it could be based on that information. And then when we do that, we start our testing process to be able to not only rule out the clinician's clinical suspicion, but we also include factors in there to rule out what we think is going on with that patient based on the information provided us by the clinician. And that's, I think that is a major differentiator between what we have instituted in our laboratory and how your typical laboratory operates. And by doing that alone, we've seen a significant increase in accuracy in determining or suspecting the disease up to about 70%, right? So in the cases that we have performed our triaging process and our laboratory personnel have evaluated the case as a whole and started testing based on that, we've seen an accuracy rate of about 70% as opposed to about 45 or 50% when it's coming directly from the clinician.
So that's a really big improvement in terms of going from, that less than 50% of finding a accurate diagnosis from testing. You're going all the way up to like 70, 75%. How does this affect the patient when we're looking at, everything comes back to that patient-centric focus? I imagine having a misdiagnosis is really going to affect treatment and mortality rates, and there's so much that goes with that when you're looking at from the patient perspective. How is treatment affected if you have a misdiagnosis? I would imagine that hematologic cancers have a precision medicine approach where it's not one medicine treats all hematologic cancers or one type of treatment. How does this affect like maybe the course of their treatment and the survival rates from this, of having an accurate diagnosis much earlier in their cancer development?
Right. Yeah. So as you highlighted, so the treatment of these types of cancers varies, right, depending on what type of cancer they've been diagnosed with. And especially in today's world, we have more and more targeted therapies that have been developed, and they have been designed to specifically target a very particular type of hematologic cancer, right? Or hematologic cancer with a very particular abnormality, right? So if that has not been identified, number one, the patient misses out on the ability of being treated with a targeted agent or therapy. But even if they don't have that as an option, right, the treatment does vary from one type to another. So one of these scenarios that can occur is the patient may be misdiagnosed with a different type of cancer than they actually have, right? So in that situation, they would be treated based on the wrong diagnosis, and they would be given the wrong agents or drugs or treatment for that. And the downside of that is obviously from a health perspective is, number one, the cancer that they do have is not being treated, right? So they're being treated incorrectly. And given that most of the treatments for cancer are toxic agents to begin with, right? So that it causes or creates a further deterioration of that individual's health in itself. Because, typically when talking about cancer treatments, it's always a cost-benefit analysis, right? And patients and their doctors are always weighing these risks. And if we're going to go down the path of treating this cancer, we need to understand the side effects of these drugs, because they all have some type of side effect, which are a lot more severe than other types of medications that are given for other ailments. And then when you're given the wrong one for the wrong disease, now the patient is only suffering the side effects of that agent without benefiting from the treatment itself. So that's number one. The other scenario that could occur, which does occur, but it's also a possibility in this. We just don't know which scenario we'll be dealing with in terms of misdiagnosis. Are of course the patients that are misdiagnosed in the sense that they're given, a quote unquote clean bill of health because their malignancy has been missed. Right. So it's not that they've been misdiagnosed with a wrong type of cancer. They've been misdiagnosed by telling them you don't have cancer, when in fact they may have a cancer that's underlying, but it's just different than what the clinician had suspected it to be. The risk that arises from that are those patients will go on without the necessary treatment, and the risk involved in that is that their cancer may progress to a later stage before it's properly identified and then they're properly treated. So then, of course, when speaking of cancer, you always hear the notion of early detection, right? Because the earlier we can detect a malignancy, the quote unquote easier it is for the clinician to treat it. The further along that malignancy has been identified, the more challenging it becomes to treat it, right? Or the success rates of treatment significantly declines, because not only are you dealing with a more progressed malignancy, but you're likely dealing with a deteriorated health in general. There are other things that occur depending on the type of cancer we are dealing with that can involve other organs. That now the clinician has to treat several things at the same time, and it becomes that much more challenging to successfully treat that individual. So the longer we wait, but the longer it takes to properly identify the right diagnosis, the potential of successful treatment decreases over that time.
So in order to diagnose properly and have that accurate diagnosis for a patient, we talked about a little bit earlier, there are different lab assays or tests that you can do to identify and the issues of physicians choosing the right test or having the right indication. In terms of in the lab of what these tests look like, what are you testing? You're obviously using a blood sample, but what are the different types of tests that are done? Is this primarily genetics? Is this more looking at other biomarkers?
We have to use several different types of tests or technologies to properly diagnose a hematologic type cancer. And that ranges from testing on a protein on the cellular surface, right, all the way down to a genetic level. Right. So, and we have various types of technologies that we have to implement and utilize in between to gather a full picture. Because if you think about it, it's sort of like a puzzle. We have to put the pieces of the puzzle together, and every piece utilizes a different technology to obtain that information. Right. So we have everything ranging from I don't want to call it simple because it's far from it, but from a diagnostic perspective, it is a simple morphologic analysis where the pathologist is viewing the cells under the microscope for their shape and size and quantification, all the way down to a genetic level where we're identifying genetic abnormalities within the DNA that's within the cells that have been identified to be abnormal. And the one major area that has become increasingly challenging is the area of cytogenetics. And for two reasons. Number one, cytogenetics is very specific in terms of the process that it takes. So in order to properly perform cytogenetics, to culture these cells in a laboratory environment, so you examine them for chromosomal abnormalities. But to be able to do that, we need to make a decision in terms of which types of cells we're going to culture for. And in order to do that, we need to know what we're looking for. And given that most laboratories operate solely based on the incoming clinical indication that's provided to them by the clinician that submitted the sample, and as we have seen in about or more 50% of the time that information is not accurate, that's the percentage of time in which a cytogenetics laboratory is culturing for the wrong type of cell, right? Because depending on the type of hematologic cancer, there are different cells responsible for that malignancy when we're talking about white blood cells in particular. So when we're looking for a leukemia, an acute myeloid leukemia, you're looking for cells of myeloid lineage. If you're looking for B cell lymphoma, for instance, you're looking for B lymphocytes that are responsible for this type of disease, plasma cells for multiple myeloma, etc. So the challenge that we have seen ourselves is that if we have to make a decision when performing the test, and we know that 50% of the time that information is not accurate or sometimes incorrect, what can we do to make sure that we obtain enough information to allow us to go down the right paths? Right. And as a laboratory, as a company, we are actually fortunate enough where not only do we have a clinical laboratory, but we have a research and development laboratory as well. And the function of that laboratory is to essentially solve problems that we are seeing in our clinical laboratory. So we have a team tasked with trying to figure out solutions for some of the challenges that we are faced with on the clinical side. So this was one of the challenges that we were faced with, so we tasked our R&D team as, how can we overcome this challenge? We have two problems at play here. Number one, we know that about half the time the information we are acting upon is incorrect. And two, we need to make a decision at the time of testing because you're also dealing with the viability of the sample you're handling. So over time, the cells, as soon as they've been extracted from the patient's body, they start to die off, right? So every cell has a certain lifespan, and given that it's been extracted from the body, it starts to deteriorate. So as a diagnostic lab, as all diagnostic labs are faced with, when they receive the sample, they have to start testing as soon as possible because then you're faced with the challenge of the viability decreasing, and that will become a challenge in itself. So this was the problem that we tried to solve, is how do we essentially buy ourselves a little bit more time from a specimen perspective. So when we culture these cells for cytogenetic abnormalities, we are certain that we are going down the right path.
It's interesting that as we talked about, we're kind of coming full circle of at the top of the show, we talked about how physicians really have to have that indication and there will be a cell line that's chosen to look at. So you're really focusing of choosing which one and saying, okay, we're going to look at this cell line and say, or these types of cells rather, and say, okay, is there any issues there cytogenetically? But if you choose the wrong one, then you could end up with information that's not helpful and not finding that diagnosis. But instead, you guys are able to take a step back and say, we're not necessarily having to choose a cell line, that you're able to look at all of these and amplify all of these or kind of allow them to grow. Because usually for people that aren't lab people like us, that you're choosing media or kind of cell food, I guess, to say, okay, we're going to allow these to grow more than other cells. But what you guys use is a kind of all-in-one media, it sounds like, to have all of these cells be able to grow so that if there's an issue in one of them, a cytogenetic change with like the chromosomes, then you're able to pick that up. That you're not limiting yourself to say, oh, we've only looked at, like you were saying, like myeloid cells. So it's really interesting that you're able to do that and eliminate saying, okay, now we're not looking at certain areas. You're able to take more of a broad picture approach.
Exactly. Yeah. And that's the product that we have developed at Precipio. And it's called IV Cell. And it is a universal type of cytogenetics culturing media. So rather than us being quote unquote forced to choose a particular cell lineage in which we are going to culture for, and as you pointed out, if the indication is incorrect and we're culturing for this wrong cell line or cell lineage, we're not going to find the cytogenetic abnormalities that are associated with the disease that this patient may have because we're looking at the wrong types of cells. And if those cells are normal, they're not the abnormal ones, they won't have any associated cytogenetic abnormalities or anomalies. So that's what we've created. We created this universal type of medium, which allows us to upfront culture for all the cells. Right? There's no need to make a decision and to simultaneously promote the growth of all the different types of white blood cells that we are assessing for. And then based on additional information that we obtain from the other tests that we are performing, primarily flow cytometry and the morphologic analysis, we are now given or provided with more definitive information that will pinpoint for us which is the cell lineage of interest. That information, we now definitively pull those specific types of cells from the culture. We harvest for those and we analyze those chromosomes. So significantly improving the likelihood of identifying cytogenetic abnormalities if there are any associated with the right diagnosis that we're making.
And once you can identify them and say, okay, now we're looking at the right cells that we're supposed to be looking at, I also hear that IV-cell increases the resolution of the banding pattern of chromosomes, which is someone that used to work on these samples, and that this is what my undergrad degree was in, was cytogenetics. Mm-hmm. That sounds amazing to not have to, for it to be very clear if there's a change there or not. When I'm saying banding patterns, for those that don't know, when you're looking at a chromosome, there's different bands on it. Kind of looks like a barcode. And so some media is able to really provide very clear that you can see it. And others, it's more fuzzy. And so that's when it becomes harder. And I imagine more misdiagnosis happening of not being able to see those changes of chromosomes exchanging material, of material being deleted, duplicated. So there's a lot of different changes that can happen. But, for those that are cytogeneticists and cytogenetic technologists, hearing that is a huge bonus to be able to have a clear banding pattern as opposed to other types of, standard media.
Yes, yeah, that's a very good point. And I give a lot of credit to cytogeneticists and cytogenetic technologists because the type of work that they have to do is so detail oriented. And the information that they have to analyze, as you pointed out, the banding resolution. So every chromosome that they're looking at has these very very unclear shaded regions or these bands that they have to analyze to make sure that they are in the right location. And I always describe it to people that it's sort of like the difference between viewing something in, closed caption TV and, an HD version of it. And the ability to pinpoint specific details on, for example, on an individual's face. On CCTV is very different than if you're given an image of high definition image to be able to pinpoint a freckle on that person's face. And that's sort of similar to the work that cytogeneticists have to do. And when given this fuzzy type of image, not only does it take them longer and is it harder for them to analyze it, but like you said, the likelihood of missing a very obscure abnormality is much higher when the image is fuzzy versus when it's, clearer and in higher definition. And that is what IV-cell allowed us to do as well. It produces chromosomes or images of chromosomes that are higher resolution than your average media to increase the accuracy or the ability of our cytogeneticists to be able to analyze these properly and identify the abnormalities if they are there.
I like that analogy. I haven't heard that before. And I can say, I was in a lab and it's very challenging to sit there for 8 hours and be looking at all of these different banding patterns and seeing the changes. It's very hard work. And I commend people that are in the field and hard every day doing it. Thank you so much for coming on the show and sharing all of this insight.
Yes, you're welcome. Thank you so much for having me.
Learn more by going to Precipio's website, precipiodx.com. And if you're looking to stream more episodes of DNA Today, there are over 100 available on our website, dnapodcast.com. Some of the podcast apps now don't have all of the episodes since it's over 100, so you can check it out by going to dnapodcast.com for show notes and lots of other information. If you're active on social media, you can follow me on Twitter at DNA Podcast. Instagram is a little bit different at DNA Radio. And any of your questions, comments, concerns, ideas, send them all in. info@dnapodcast.com. And one more favor, please rate and review on whatever podcast player you're listening to it on. If you're listening on the radio, jump onto one of your podcast players and please rate and review the show. It really helps to boost our visibility and gain new listeners like yourself. Don't forget also that our next episode launches our fertility series, which will take place over the next couple months. So look forward to enjoying that. Before wrapping up the show, I want to remind you about Picture Genetics' exclusive 25% discount for you since you're a DNA Today listener. Picture Genetics is different from direct-to-consumer tests because it's actually clinical grade testing. Every case is reviewed by a physician or a genetic counselor, and this genetic testing is not genotyping. Rather, it looks through entire genes, not just certain points. Results are focused on health with medically actionable and useful information for both you and your family. Genetic counseling is also offered so you can fully understand your results. There are privacy concerns with direct-to-consumer genetic testing, but again, Picture Genetics is clinical grade and does not sell your information or genetic data, period. Their business model is to provide consumer-friendly platform so that everyday consumers can access their DNA analysis using their existing expertise and HIPAA-compliant clinical lab. Your DNA is personal. They'll keep it that way. Check it out at picturegenetics.com and use code DNA today for 25% off and free shipping. Thanks for listening. Stay safe, everyone, and join me next time to learn and discover new advances in the world of genetics.
The genes of you and me, the genes of you and me, are all made of DNA. We're all made of the same chemical DNA.